All right, students, a lot of you have been asking me, why is fat transfer or fat grafting not a more popular type of breast volume enhancement? Well, to understand why we don't use it as much, we have to go back to our high school biology and chemistry days. So stick with me for some basic science to learn more about fat grafting. Take the example of a kidney transplant. This donor kidney brings in its own artery and vein, is connected to the recipient, which now will supply new blood supply, oxygen, other nutrients to keep the kidney alive, perfused, and it can do its job. However, transferred fat cells rely on diffusion of nutrients across the cell membrane here to survive. There's no artery and vein that comes with them, and the cells in the center of a fat glob tend to not get as many nutrients and die. Some of these dead fat cells do get absorbed by your body, but not all. What you can actually have is little collections of oil called oil cysts that can be aspirated with a needle, and some will get hard in a process called fat necrosis, and calcium deposits can develop through a really cool chemical process in your body. The negative charged fatty acids bind with the positive charged calcium in your body, creating essentially soap. It's called saponification. So why do we care about this basic science, your pathophysiology? Well, let's talk about some clinical scenarios. Let's say you had some fat transfer to your buttocks or hip dips. Worst case scenario, although I've seen this, is that it dies, it gets infected, and turns into what looks like pus. But more likely what will happen is that you could get some lumps that you can feel and calcifications. I guess at worst you have a lumpy butt. But let's say you transfer to your breasts, okay, and some of that fat melts away. In the process, you could get a palpable mass that you can feel, can cause anxiety. You can get oil cyst that needs to be removed, or more likely, what will happen is calcifications on your next mammogram. What else presents with calcifications on mammograms but DCIS and cancer? So many patients who have had a history of fat transfer will need additional imaging, as here 15 to 20% of patients in this study. And that can lead to additional biopsies as well. So only you can decide if the potential aesthetic benefit is worth that little bit of anxiety and additional imaging and biopsies. I'm not going to poo-poo fat transfer. Full disclosure, it is a game changer, especially in the breast reconstruction world and other contour deficits, like patients have craniectomy. But do know that even these patients often need several sessions, 2, 3, 4 times to inject the fat, because again, some of it melts away in the process and we're building up a base. But do know that some of my breast reconstruction patients have had fat necrosis in their reconstructed breasts, leading to additional imaging and biopsies and anxiety. So please remember, you will never get a full cup breast enhancement out of fat necrosis because of that physiology that I explained, that the center of a fat glob will likely die. So only you can decide that that small benefit of potential maybe medial cleavage or upper cleavage is worth the potential for additional imaging and biopsies. I hope this was helpful. Please drop any questions or comments below. Thanks for watching.